Welcome, my friends, to the Bob and Brad podcast produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and I'm exactly one half of the Bob and Brad team. Today, we're going to talk about how to rehab your lungs after COVID-19, pneumonia, and/or surgery. By the way, before I go any further, I do want to mention that I had some recent surgery, and so if I sound like I'm drunk or slurring my words, both may be true. No, I do have surgery, and it's numb, and there's some scar tissue there, and it's making me difficult to talk. Today, my guest is Dr. I'm going to screw up this name, but Sigfredo Aldarondo, and he's a board-certified internal medicine, critical care, pulmonary disease, and pulmonology physician. He earned his medical degree from the University of Puerto Rico. He went on to complete his internship and medical residency, that's what I'm talking about, at the Veterans Administration Hospital in Washington, D.C. He completed his medical training with a fellowship at Brooke Army Medical Center in Fort Sam, Houston, Texas. Dr. Aldarondo, thanks so much for joining us. Okay, welcome to the program, Dr. Aldarondo. I probably screwed it up already. I'm just going to call you doctor. Really appreciate you taking the time. Really some valuable knowledge that we can glean from you. And I'm going to go ahead and get started off. Now, you're a pulmonologist, correct?
Correct, yeah.
Would you explain to the layperson what that is?
Well, a pulmonologist is somebody who has done a subspecialty after doing an internal medicine residency, a subspecialty training or further training, call that a fellowship, in pulmonary medicine. So concentrating
on the lungs.
On the lungs, right.
Yeah.
Concentrating on lung diseases of diverse types, from chronic, mundane, to severe, to acute and chronic, the whole spectrum. But basically, we devote our skills and energies in the diagnosis and treatment of lung diseases.
So am I right in saying that in some cases, you're kind of the lead guy, like it's supposed to the patient with lung cancer, but maybe in a different case, you may be called in for a consult?
Correct. Actually, in the acute setting, in the inpatient setting, the majority of the times that we get involved in the care of somebody is when we're asked to see a patient as a consultant.
I see.
If the pulmonary problem is the most important, severe one, we basically take the lead in the directing. In the outpatient setting is a bit different because, yeah, we see patients as a consultant as well. But patients who have primarily a severe chronic lung problem, we pretty much become their main anchor physician in caring for them throughout their illness.
So have you been seeing many COVID patients, and are you the lead person on those?
Many times we are. The answer to your first question is, of course, yes. Unfortunately, yes. Both in the acute and the chronic setting. And in many of these, we are actually the main physician. We do collaborate quite a bit in this particular disease with infectious disease consultants as well. So usually we are collaborating with an infectious disease physician as well.
Gotcha. Are people with lung problems at a higher risk for obtaining COVID, or are they just more at a higher risk for having more severe issues?
Yeah, rather the latter. No. There is no evidence that by having any certain type of lung disease, you're more likely to get infected. The infection seems to be more of a function of the virus itself, that is highly infectious and contagious.
Sure.
However, if you get infected and you have chronic lung problems, yeah, you're more likely to have more severe complications.
Would you mind taking a minute to talk about maybe patients with moderate to severe COVID and what kind of things are going on physiologically with those patients?
Sure. So the virus is primarily a respiratory virus. It reaches the host through the airways. usually the nasal passages.
Sure.
And the initial symptoms are related to the respiratory illness. The patient may experience mild systemic symptoms. The majority of the patients, by the way, will have a mild clinical course, the majority. And in some cases, actually be totally asymptomatic,
Sure.
which is the treacherous portion of this, that, you may be totally asymptomatic and yet transmit the virus to somebody else, who then
Right.
may do that well. But the mild presentation is pretty much very vague and very much similar to the common cold. Okay, you may have
Gotcha.
a little headache, a little nasal congestion, maybe a low-grade fever, and within a few days you're over it. However, what we're seeing is that unlike the common cold, there is a substantial number of patients that will progress into more severe phase. In which case now, by the way, the incubation period with the Delta mutation, Delta variant is shorter. So we're
Sure.
talking 3 days between infection and symptoms onset. So the next phase, if you will, the patient will have now more severe systemic symptoms: headache, persistent fever, cough. Now the cough becomes more evident. And at that point, the patient will have a completely normal chest X-ray. They will have normal oxygenation and nothing alarming yet, okay? When that starts happening, then unfortunately, there is a very thin threshold to then develop more severe symptoms. That's why acknowledging the likelihood of infection, acknowledging your underlying comorbidities, that's the time when intervening with monoclonal antibodies can make a huge difference
Sure.
in mitigating the evolution of the illness. So unfortunately, we see that. I just saw a patient earlier today, 2 hours ago, who hopefully will be okay, but has been hit pretty hard. And he was asking me that same question: why didn't get this? And I said, well, unfortunately, I cannot answer that question for you. He should have. There's underutilized in our community. But anyway, that's the moderate phase in which the patient will have some symptoms. And at that point, the likelihood of progression is now significantly higher.
Sure.
And unfortunately, once the floodgates open, now the severity of the illness is not the virus anymore. It's actually the inflammatory response of the host against the virus. That's why the treatment early on that can work against the virus, which is the monoclonal antibody,
Sure.
and an antiviral agent that we use in the hospital called remdesivir, is only helpful early on, because that basically is a drug that is directed at repressing the viral replication and its secondary problems.
Gotcha.
Once the severity of the illness increases, and the problem now is a systemic inflammation, now we're talking other things that we try to do, which is why we use corticosteroids, dexamethasone, and we use other agents that are directly at the blocking the impact of those proteins that are released, the interleukins, particularly IL-6. So we use another monoclonal antibody called tocilizumab, or other drugs, another one's baricitinib. Basically, these drugs are now trying to block the inflammatory response, okay? And they do help a bit, but it is no way to predict, once the patient crosses the barrier, who is going to be the one that will be deteriorate quickly, end up on a ventilator. Right now, I just saw a patient 2 days ago, 31 years old, completely healthy, obviously unvaccinated, who is on a ventilator and his lungs are destroyed.
Oh my gosh.
31 years old, previously healthy. So we have a subset of people that will progress to that degree, and we don't know what are the risk factors for that to happen. Now we know that those are immunocompetent transplant patients or immunosuppressed for other reasons will be more likely to progress. Will likely to, but we have seen patients like that who actually did well. So it is not as a guarantee.
It's just a mystery.
It is. What we do know, and just that led to the most recent recommendations regarding the booster shot, is that those people that are immunocompromised may not benefit much at all from the vaccine.
Oh, really?
their antibody response, the immune response to the vaccine is completely dwarfed or significantly less potent, if you will, than the normal host. And that's so people that are vaccinated who know are less likely to be protected by the vaccine are the ones that should be front row to get the booster shot.
This inflammatory response, how does it present itself? I mean, what are some of the damages that the high level inflammation can present?
Yeah, good question. The most striking and prevalent problem is the respiratory apparatus, the lung injury that results in severe drops in oxygenation or respiratory failure. Okay, but also may be associated with endothelial inflammatory changes. So the lining of the blood vessels, the lining of the blood vessels is impacted so that there is a preponderance of thrombosis. So there's a high risk for
blood clots.
Blood clots in the venous and arterial too.
Oh, really?
Yes. So, and that may be associated with coronary ischemia, with cerebral strokes, and for example, and venous thromboembolism. So blood clots in the lower extremities that reach the pulmonary vasculature, which is, by the way, one of the reasons why we always use anticoagulant therapy on our patients as a preventive measure.
So are you talking about, at what level are you talking about? Are we talking about the bronchi, bronchioli, or alveoli? I mean, any level of those?
The most striking and most important level or site where this is relevant is the alveolus. Is
the blood exchange. The
alveolar capillary membrane. Yeah, in the beginning, all the respiratory tract is affected. So there's a lot of bronchitis early on, cough, and not only just cough. Many of these patients have this severe pain. The tracheobronchitis is really out of proportion to other things. They really complain to you of severe pain, which is one of the reasons we mainstay of therapy includes inhaled corticosteroids on our patients. Aside from the systemic theories. But to answer your question, is the air sacs, the alveolar.
Why do you think the loss of smell?
Well, the olfactory sensors that we have in our nasal passages are, it is the first barrier. The nasal mucosa. Well, by the way, we have a high concentration of nitric oxide in our upper respiratory tract. So the inflammatory, there's afferent sensors or nerve afferents in the respiratory tract that also have to do with the sense of smell and taste as well. So they basically it's a secondary casualty. The thing about it is that there's in some cases it's thought that becomes an important thing to identify because it may herald CNS complications or encephalitis. It is not really proven to be the fact, but there's some speculation that there is some correlation between that event and the severe headaches and sometimes even encephalitis that some of these patients have. But it is just part of the respiratory tract. Okay.
My gosh, it's really cascade of events. So are ventilators considered harmful now or helpful, or where are we at with that right now?
It's funny you asked me that question because the same patient I was telling about was telling me, my wife just told me, don't let them put you in a ventilator because we have two people that went on ventilators and died.
Sure.
And I said, look, the issue is, look at it differently. When the disease escalates to that level that you need mechanical ventilation, it's a big flag that is a very serious now illness, and your lungs are failing. So nobody will put you in a ventilator just because. The fact that it's done means that your lungs are failing. Now, back to your question, in the beginning of the pandemic, there was this notion that we wanted to avoid mechanical ventilation because it was potentially damaging and this and that. Mm-hmm. Well, the answer to your question is when mechanical ventilation is necessary, it is done. It allows the clinician to, in a more reliable way, ensure that the oxygenation to the body is maintained. It gives you an opportunity to do what proning, what we do is put the patient on their tummy to improve their oxygenation by improving the relationship between blood flow and oxygenation. So, and it allows you to care for the patient better.
Gotcha.
There's always a downside. So intubation, mechanical ventilation needs to be done in a certain way so that we follow certain guidelines so that the lungs are not injured in the process. So we know we've learned a lot about how to manage respiratory failure over the years, and we apply that information and how we deal with COVID patients. So there's no contraindication to intubate and initiate mechanical ventilation. But when it happens, rather do it in a semi-elective way than in a rush at 3 o'clock in the morning when the patient has respiratory arrest.
Sure.
That is, and by the way, for the sake of the personnel caring for the patient, gives you everybody to have their PPE on, their protection, so that it can be done in a safe way, so we don't spread the virus around others that are caring for the patient. So that needs to be taken into account.
And that is a big concern. Also, when you're able to move along further and start rehabbing the muscles, you got to be aware of that. They're still symptomatic or could cause symptoms. I mean,
sure. Well, not that it causes symptoms. Patients that are rehabbing, like any other patient who's recovering from respiratory failure and acute devastating critical illness, they will be weak. There'll be generalized weakness. There's a well-known entity in the ICU. So COVID patients are no different. So we do initiate within our means everything that we can to rehab these patients. But in this case, you're right, Bob, is the fact that we have to be mindful this patient may still be contagious. So how we do that, we are mindful of that. Our respiratory therapists know that very well. And the patient is instructed. They explained what to do, and they can, if they do anything that will be potentially aerosol generating, they'll be by themselves when they do that.
Sure, gotcha. So we've kind of talked a little bit about the medical portion, medical management of these of COVID. So now I'd like to move on to more of the training that would go on for the respiratory muscle training. That when would that occur, and at what point would you initiate that after COVID?
Thank you for the question. If I have a patient who is cognitively functional and able to cooperate and follow commands, and the patient's oxygenation now has stabilized, so they basically are not requiring either BiPAP or non-invasive ventilation or invasive ventilation. Basically, they're oxygenated with a nasal cannula.
Sure.
So they have access. Their lips, oral cavity now is available for exercising of the different types. That's the patient that I would initiate that. It's like anybody else who's now been subject to an acute injury, respiratory injury. So what we do is we encourage the patients to participate with a series of, we do emphasize mobility as much as we can. So that means getting off their back.
Getting movement, yeah.
As you know, you in your field, you know that. So, but the thing that is many times overlooked is the importance of exercising the respiratory muscles. And so we provide our patients. I am a strong believer, which is why I'm here talking to you today in part, of the importance of rehabbing our respiratory muscles. So we do that when the patient is oxygenation now allows us to do that. They're obviously stable in other regards. They don't have any recovering from a major stroke or have cardiac issues or major arrhythmias. The same rationale we follow for other patients that are recovering from acute respiratory injury.
So pneumonia, or maybe even just after surgery, be the same thing. Sure.
Yes.
Well, how do you train the person safely without getting infected yourself?
Well, we demonstrate it to them. Okay. We have I have one of the devices here. I can show it.
Yeah.
This is the device that we use. It's
Called the breather.
called the breather. So it has a port for inhalation and one for exhalation. So and you can separately adjust resistance for each side. So we basically assess, the patient is instructed how to hold it, how to properly place your lips around it, and the technique. And then we demonstrate, we actually have a glass window we can actually look through.
Gotcha.
And observe the patient at a distance. Now, we also, everybody's wearing N95 and PPE, so you can step back several feet, even in the room, and observe the patient as they're doing that. So you don't need to be there in front of them. And we observe how they perform. And they're instructed to initiate the process, and then it takes a while to get reinforced, to be re-educated until they basically get the hang of it. But it's a way to exercise not only the diaphragm, but the accessory inspiratory, expiratory muscles, the belly muscles, the core muscles, all those things are part of this. So when you think of diaphragm only, but there is a number of muscles in the thorax and abdomen, all participating in the process of ventilation.
And they all got very weak.
Completely, right, for a number of reasons, particularly if they had been on mechanical ventilation.
Sure.
Because we know that from day one, once you initiate mechanical ventilation, the diaphragm starts to weaken and gets thinner and thinner. We know that by ultrasound measurements. Everybody, but particularly those patients who have been on mechanical ventilation.
That's very interesting. I mean, that's a big, thick muscle that covers the lower end of the abdomen. So, yeah. Oh. Yeah. Brad always brings it up when he goes deer hunting, that when he dresses a deer, he can see the diaphragm. So, but I want to make that point again, that you can actually adjust the resistance breathing in and breathing out. I think, what is it, 4 or 5 levels of resistance?
For inhalation, there are 5, and for exhalation, there are 6.
Gotcha.
Yeah. So, but
I'm guessing most people started at 1.
Yeah, most start at 1, but 1 is hardly any resistance. And many times I end up starting our patients at level 2 right off the bat. You can tell their effort is not. So we get feedback from them on their effort, if they experience fatigue, and at what point they experience fatigue. We try to hit 10 reps inhalation, exhalations twice a day, and sometimes 3 times a day.
Yeah, I want to make this point too. I mean, you were saying you can do this with the oxygen. So like if you have COPD, you can do this to try to improve your.
Well, actually, Bob, this type of the rationale to use respiratory muscle training started 40 years ago, mostly for COPD patients.
Sure.
And it's called respiratory muscle training. Because doing that, you'd show that you increase respiratory muscle strength, and patients' endurance improves. So they're able to carry out more tasks. Their shortness of breath decreases. So when you do rehabbing or pulmonary rehabilitation, in our program, we incorporate respiratory muscle training always as one of the interventions that we do. So for COPD, it's been a no-brainer for many, many years in our institution and many others that respiratory muscle training it's helpful. Now, what we have done is we have learned that respiratory muscle dysfunction and/or weakness are not only the domain of COPD patients. It happens a lot. Happens patients with congestive heart failure. Happens our patients post-operatively.
Sure.
Patients that have been mechanically ventilated for a number of reasons, day 2, day 3, day 4 afterwards. So it is a very prevalent issue, and both in acute, subacute, and chronic stages.
Which makes total sense. You know, you realize how weak you get after surgery on the visible muscles, but so it's obvious that the muscles inside are also getting weaker. So they have to be addressed. And I think I think with COPD, if you can, for somebody, the goal might just to be able to go out and get the mail again, or, play with their grandchild. I mean, they may not be big goals, but you can change the trajectory of your outcome, I think. So, um, I know the answer to this because I've looked up the research on myself, but there is research backing respiratory muscle training, correct?
Lots.
Yes, I thought so too. Yeah, plenty of it. And I got a kind of an interesting question. So when I was in the hospital, always working with patients, you would see a lot of this spirometer. Now, the incentive spirometer, that's really not a training device. I mean, it's not a muscle training device, is it?
No, it is not. There are different ways to describe it. Some of them I will not use the comparison here or the metaphor, but it is actually being acknowledged by the proper institutions that incentive spirometry doesn't really do a whole lot. What you do basically is you see in a chamber what your volumes are.
Sure.
So by seeing your volume go up, it may incentivize you to do a little better.
Sure.
But you're not really doing much work when you do that.
Sure.
Okay? It's like trying to lift. You pretend you're lifting weights and you're moving your arms, but you don't have any weight.
Right.
Adding weights. Now you're doing work. Now your muscles are at a medium resistance. Now you're recruiting mitochondria. The mitochondrial density of your muscle improve. That you improve the efficiency and so forth. So this is so much different and better. So I tell my patients, when they always get an incentive spirometer there. It's like guaranteed. Somebody will park one there. I said, that's okay, but you're going to do this.
Right.
One battle for the looks, but.
Right. I think it seems like the incentive spirometer is kind of just a feedback mechanism. I mean.
Yeah, it's a visual feedback.
Yeah.
Right? But there's not much work at all.
Right. Are there other devices? I mean, I thought I saw some devices that handle one end of it, like the inspiration and not expiration, and
there are other products in the market. There's one another that is often used or has been, but for the majority of the ones out there that are competitors, whatever, they only provide the inspiratory muscle resistance.
Gotcha.
Our device is created by, he was the respiratory therapist who actually created that. And the name of the company is named after her.
Oh, cool.
The PN comes from her name, and PN Medical. So it was quickly recognized, to her credit, and others that collaborated with her, that, hey, expiratory muscle function, or expiratory, the components of inspiration, you don't only inhale, you have to exhale. And when you cough, you exhale. When you speak, when you phonate, you exhale. So there are a number of muscles there that are important. And if you can maximize the efficiency and endurance of the whole shebang there on inspiratory and expiratory muscles, you're doing the patient a good service. There's actually data coming out very nicely in other issues that are not only ventilation, such as dysphonia, dysphagia, stroke patients. They have upper respiratory muscle weakness. By using this device, you improve phonation time, you potentially improve the ability to cough, which is important to clear the airways and prevent excessive mucus buildup and infection and so forth.
So I do want to mention that website. We'll have it down below too in the comments, but www.pnmedical.com, pretty simple. And like you were saying, it can be used with people who are having trouble speaking. Would that include Parkinson's disease?
Yes. Okay.
Yeah. And I wonder if you just mentioned real quickly too, sleep apnea. It's such a big problem too now. I thought there's been some research that shows that it may help with that too.
Yeah, there's some data, and I don't think the data is as solid as it is with
with
COPD
COPD. Yeah,
and demonstrating the importance of diaphragmatic or respiratory muscle strength and so forth. But if you can improve the muscle tone of the upper airways, okay, and the decrease a bit that airway collapse that happens during sleep, and you can improve your sleep pattern, by coupling respiratory muscle training with proper breathing and relaxation and so forth, and your sleep quality improves. You may actually see some benefits from that, but I don't think, to be honest, that we can connect the dots and say that
sure.
if you use this device, you're going to mitigate your sleep apnea. No, you can't really say that. But it's just one more thing in terms of sleep hygiene and respiratory function. And if you have obstructive lung disease, if you have respiratory muscle weakness already, then it makes sense to do everything you can to optimize that, so that even in your sleep, you may not see as much secondary consequences.
Yeah, it's certainly not going to be bad for you.
No, not at all, of course.
So let's say you have a person here that's recovering from COVID or has COPD or has dysphonia or whatever. I mean, they can initiate this on their own, right? They don't need a prescription.
No, they don't. And the website actually provides information for the patients. And there's some informational didactic videos, a lot of resources for the patients can use. And there's a lot of research there, by the way, that they can tap on. It's always best to do this with the consent and
Sure.
and encouragement of their physicians or provider. But no, you don't need a prescription. What is important is, though, that there's a rationale for it, that there is a clarity of purpose, that the patient is not barking at the wrong tree by doing so. They expect there's some completely unrealistic expectations, right? But if you recognize that you are in this group, and you mentioned COVID, Bob, let me just tell you, as you know, we're dealing with an explosion of acute post-COVID syndrome, or the long hauler. And this is something that is still unraveling, that we're trying to understand. But generalized weakness, fatigue, shortness of breath in diverse forms and so forth is part of it. And there's some other patients that have dysautonomia as well, added to that in different ways. We're looking into that. And actually we're participating, we'll be participating very soon with a major academic center in the how to, by incorporating respiratory muscle training, among other things, how we can help these patients to deal with this entity, which is, it's just a big deal. It is, I'm seeing in my practice every day 2 or 3 new patients post-COVID now.
Sure.
And by the way, you don't need to have a severe COVID infection to have the post-COVID manifestations. The majority of these patients actually had a mild illness.
Really?
Mild. And then this secondary wave of what maybe a post-acute event, post-inflammatory state, or is what we're seeing. So it is deceiving when you think, well, I just had a mild. No, it's actually has nothing to do with that.
Yeah, it's funny. I had pneumonia several years back, and pretty severe case, and I recovered. And then months later, I was at the dentist, and my dental hygienist used to be a respiratory therapist, and she still could pick up on the wheezing that I had, and that was months later. So, it's amazing. Like you said, the weakness can completely manifest itself years later or months later yet. So, with the breather, I want to just mention too, I saw the videos on training. These are really excellent videos. I mean, I realize it's better to be with maybe a professional, but because they can give you feedback, but these are really easy to follow lessons, and they do better than we do trying to explain how to use it. So I I'm also going to mention, I know this is kind of on a side, but I had a little bit of an interest in this. They have the breather for, and I don't know if you know anything about this, but they have the breather for basically athletics. Now my son was a big runner in college, and I really am upset that I couldn't have tried this with him because I didn't know about it. But I think it would have gave him an edge. It just makes so much sense to me that it would have been a way to focus on strengthening the muscles that he needed.
Yeah, I'll have another one here with me. We call it the breather fit.
Sure.
This is the one.
That's the one for athletes.
Exactly. And basically, this came out of a appreciation that people at high performance situations, mostly athletes or professional athletes and so forth, they are whatever they were maybe swimmers, divers, and track, whatever, they do experience a little edge in improvement, and the data is around that is significantly thinner, lighter than what we have on the clinical side.
Sure.
But there's enough information there and enough some of these anecdotal, and the studies are in progress, that we have seen an enormous interest, and that's what led to this other. But the difference between this one and the other is that the resistance settings are significantly higher.
That makes sense.
Significantly higher for a completely healthy individual who would not really benefit much from doing this.
Yeah, to me, it makes sense. Like as a runner, you know, you're running, you think you're strengthening your running muscles when you do this, but you actually need to include some weight training to strengthen the muscles that you're running with too. Otherwise, your muscles have become too efficient and they don't work as hard. So it's the same with, to me, it makes sense that the lungs, the accessory muscles, the diaphragm also could use a little boost with athletics, especially swimming and running. I feel so. That's just, again, kind of a aside, but I really don't, I didn't have any other questions, Dr. Aldarondo. Is there anything else you wanted to cover at this point?
Well, to me, so let's to be clear, we're talking respiratory function.
Right.
We're talking about the process of ventilation, right? Is basically the bellows system that allows us to create negative pressure so that we get an inflow of gas. Then that gas reaches the alveoli, the air sacs, and oxygenation happens. But oxygenation would not happen unless you had that ability to ventilate, right? And that ventilation is what's impaired progressively with COPD patients. And that effort that goes with ventilation is now increased. And it's a vicious cycle that results in less and less activity, and the less activity, more weakness. And that vicious cycle is what pulmonary rehab breaks, right? So we try to, in a safe way, retrain that individual to exercise. And not only they discovered, mentally and emotionally, what it's like to be this way, but there's a muscle memory that is awakened, if you will.
Oh, sure. Makes sense.
So this applies to anybody else out there who is, by virtue of severe kyphosis, for example, or the spine, the thoracic cage is deformed, or scoliosis, or post-polio patients, or a number of entities in which the rib cage is altered. Ventilation becomes more and more challenging. You can break that vicious cycle by doing this type of thing. And the other thing I like to say is that I've become more and more aware of the importance of core muscle strength in terms of patients, particularly the elderly, regarding their gait, posture, and balance. And the number one cause of trauma in this country is falls.
Right.
As I tell my patients, it's not falling from the roof. It's
Right.
falling from your own feet.
Yes,
And it's devastating when it happens.
it is.
And sometimes lethal. Anyway, the point is that if you look at their respiratory muscle strength on these patients, 90% of them, they have a decrease what we call MIP, maximum inspiratory pressure or expiratory pressure. When in our lab, we measure that. So my point is that patients who may not have a primary pulmonary problem, but because of lifestyle or because of the musculoskeletal issues or other things and experience progressive weakness, they actually may benefit, they should benefit from any kind of physical therapy, occupational therapy process. But in conjunction with that, they should also should not ignore the benefit of training the respiratory, and more than respiratory, I call them my core muscles, because these muscles that share functions. It's not only ventilation,
Sure.
but also balance and gait and so forth.
So I would think that would apply also to cardiac patients.
Absolutely.
Yeah. I would think that, I mean, has your hospital been, or your clinic, have they been incorporating that as a matter of?
We do on a cardiac rehab program. It is not a mainstay or a standard thing to do. It happens more spotty there than we do in a pulmonary program.
Sure.
In our patients in the floors with cardiac issues and so forth, with heart failure, I do very often because
Sure.
I'm sensitivity for that.
Right.
But I look for it, and when I identify that it is, but it's been shown patients who have congestive heart failure, this patient will have respiratory muscle weakness. Okay, all
Sure.
of them.
Makes
And actually by exercising their respiratory muscles indirectly may actually decrease sympathetic tone, and it has a beneficial impact on cardiac function because of decreased afterload. Basically, it improves cardiac function. When you unload that increased adrenaline surge that comes from weak respiratory muscles. So it's another physiologic phenomenon that we know happens, which plays out to some degree in many of these patients.
I would think certainly in the patient who's underwent, a CABG or some type of cardiac surgery,
Indeed,
yeah.
Bob. Actually, there's studies showing that pre and post-operatively for open heart surgery, it doesn't have to be CABG, so it could be a valve replacement.
Sure.
If you optimize respiratory muscle function before and use it immediately post-op, you decrease the reintubation rate. They increase the weaning process, so they extubate even faster, and they actually progress better. And remember, everybody who has surgery, one of the goals is to get them mobilized in the first day, up on their feet,
Right.
and so forth. But if you're very short of breath, it's going to be more difficult to do that. So if you improve the patient's respiratory function, ventilatory function, the respiratory muscle dysfunction is not as key. They can be more engaging with the mobility, the PT and OT and so forth at the same time.
I mean, you could start this, as we mentioned already, you could start this with oxygen on. You can start it in bed. You could start it in a wheelchair. I mean, that's the advantage of this.
The beauty of it, yeah. Very simple and safe.
I want to say too, this is not a real expensive device.
Oh no. Compared to many things, it's dirt cheap.
Yeah, it is. It's dirt cheap. It's that's what really attracted to us to it, because our goal at the end of the day, and I'm sure yours is too. I mean, we're trying to help as many people as we can. I mean, that's
Amen.
Our outright goal. And before I'm put into the cold earth, I want to know that I was helping people and helping a lot of people. So, well, Dr. Aldarondo, please, thanks again for joining us. And we got the website, www.pnmedical.com. We'll have it down below. Leave comments for Dr. A, and he might respond. Who knows? But we don't hold him to it because he's a busy man, especially with the COVID right now. So thanks again,
We-
Doctor, for joining us.
Thank you, Bob. It's been a pleasure.
Yeah.